A pleasant good morning to you. It is 10:16 Eastern Caribbean time, and we're so happy that you've joined us for yet another episode of Health Vibes, brought to you by the brand you trust, Jolly's Pharmacy. Again, we are delighted that you have decided to stay tuned with us today on this very interactive yet very informative episode of Health Vibes. Today is World Lupus Day, and we are standing in solidarity. Though I'm wearing a yellow shirt, and I'm seeing Jacinta in her purple. Is it purple lilac? Purple, and Trudy has a purple belt. Don't worry, for black and whites, but she has her purple belts, and so we all stand in solidarity to the champions, the fighters, the survivors of lupus, and we know that it is a chronic disease, inflammatory disease that is affecting so many, primarily women, in this world. And so we stand. I think the news item said this morning over 200 women in Dominica have been diagnosed with lupus over the period of time. And so we standing with them on World Lupus Day. We standing with you, we are at the back of you, and we are holding your hand while you fight against this dreadful disease. Trudy, good morning, and Jacinta, good morning. Good to have you back after it's like a month you've not been here.
About a month.
Yes.
About a
Morning
month.
to
Good
both of you
morning.
and to our listening audience.
Mhm.
It's good to be back.
It's good to be back.
Yes.
All right, I'm going to run through a few things very quickly because we have a very important guest. I don't want to have him holding on so long. I'm just going to run a few items quickly. Mother's Day is this weekend, and we are excited again to bring to you another very innovative yet interactive activity to commemorate Mother's Day. And this year we are having a challenge. My son did my makeup. And so, sons, nephews, grandsons, once you consider that particular person the mother of your life, in your life, you can sign up, and we will provide all of the products right there, and you will do your mother's makeup as a challenge. I will not know. I don't know the difference between concealer and foundation. So I think my mother's face would be a mess at the end.
So you cannot take part in that
I
challenge.
just want to say, are you able to partake?
I remember the lipstick where it goes, and that's about it. Now you have
Okay.
eyelashes and
Mhm.
you know
I shadow,
Yes.
at least.
all of that. So it's going to be
It's
very
complex.
active, very interesting. And it's going to be carried live as well. We're asking people to register. I think we have maybe two names. We're looking for at least five people. So if you want to win something really good for your mother, why don't you register as of now? The first prize, a voucher for 500 with $500. The second prize, a voucher with $200, and the third prize, a voucher with $100. And guess what? All of the cosmetics that you would have used, all of the makeup remains and will be your mom's. So we are not taking them back. So it's a win-win for everybody. And it's a good way to bond with your mother. So that's what's happening Mother's Day. We are also having a sale on synthetic weaves.
Weave, yeah.
And so for the ladies that want to buy weaves and so forth, we have a 25% off on those weaves. And so you can come in right now and do so. Tomorrow is a very important day. We are having the prize giving or the donation um, uh, prize giving ceremony for the monies that were raised for the 5K run that we had in March. Again, checks will be given to the Dominica Dialysis Association, the Lupus Foundation of Dominica, and the Ray Astor Foundation. We will be doing that formally. That will be live as well on Emo News, and other media houses will be there as well. That's going to be taking place at Prevost Cinema Mall tomorrow morning. So those of you who have been wondering, I've not heard anything. Yes, we had some delays with some of the checks from some of the corporate sponsors, and now that we have gotten all of the checks, we can now distribute that money to these
Nice.
NGOs. And so we're excited to be doing that. In the month of May, we're looking at the last week in May. We are planning a female reproductive and sexual health clinic. It's a screening for women 21 and above. I think the pap smear begins at what age? And once you're sexually active, from 21?
Yes. It can be from 21 or 4 if you're sexually active.
Right. Okay.
Yes.
So we will be doing at that clinic. It's 2 days.
Mhm.
Pap smears and breast examinations.
Okay.
And those will be done by healthcare providers, preferably mature retired nurses that we have.
Mhm.
There'll be a doctor as well as part of the team, and we will be doing this. I will give you some more information, but that's going to be happening at Borsate Clinic. That's Dr. Lisa Jolly's office. And it is going to be from 9 to 4 on both days. And if you want to do that, it's only going to cost you $25. All right, for the consultation, for everything.
Mhm.
And you can call Jolly's Pharmacy 448-448-3388, and you can see, listen, I want to be part of this. I want to have my pap smear done. I want to have my breast examined to just make sure everything is fine. There is a doctor, so if in case an examination is done and something is picked up or seen, you can get a prescription and you can have it addressed. So we are doing all of these activities for you, because of you, because we care for you. Right? As we've always said, your health, our health is our greatest resource, and we have to preserve it. And so these are some of the activities that we want to highlight that are coming up soon. And we hope that many of you will participate. So without further ado, what we're going to do, we're going to take a short break, and then we will introduce our guests for today and the topic for today. It is going to be very interactive. We do expect you to call and to ask questions if you do have questions. Thank you so much. Stay tuned.
Oh, and if they say convenience could make a big difference, then you can trust me. I know just where you should be. And that is JP Mega, 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 Mega. The one-stop shopping, Dominica, nigga, 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 nigga. You could be shopping and having fun. With your daughter or with your son. They cater to everyone. What a happy place, happy place. Oh, JP Mega, 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 Mega. The one-stop shopping down in nigga, 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 nigga. You could be shopping and having fun. Bring papa and mama along. We cater to everyone. What a happy place, happy place. Oh, what a happy place. Purchase 6 or more of any item and you automatically qualify for a discount. Check us out at the Mega Store in Funkole, where there's lots of parking on Monday to Friday from 9 a.m. to 7 p.m. On Saturdays from 8 a.m. to 6 p.m. and on Sundays from 10 a.m. to 2 p.m. JP Mega, the best family shopping experience. Who say health cannot have vibes? Well, Jolly's Pharmacy is proving you otherwise. With Health Vibes, every Wednesday morning on Q95 from 10 a.m. to 11:30. Health Vibes, education, information, and a bit of humor. And not forgetting lots of vibes. Hosted by Carlton Langdo with co-hosts Jacinta Fagan Defo and Trudy Kristen. Jolly's Pharmacy is bringing health and vibes together every Wednesday, so be sure to tune in. Health Vibes every Wednesday on Q95 from 10 a.m. to 11:30. Jolly's Pharmacy, leading the way in healthcare.
And we are back with you. Of course, we are here on Health Vibes. And as Carlton promised, we have a very interesting show lined up today and a very interesting and competent guest who is no stranger to, to Q95 at all. So this morning, we have with us Dr. Dale Dangleben. We have virtually with us Dr. Dale Dangleben. And Dr. Dangleben is a trauma surgeon, and I'm sure many people have, heard him speak before. He's also an author, a Dominican, and I know he has a great art collection. He might want to know how I know this, but I I am very privy to his art collection as well. So Dr. Dale Dangleben is a double-boarded surgeon, trauma surgeon in general and trauma surgery, and he is the medical director at Mercy Hospital. Dr. Dangleben, you will make sure that this is a correct introduction that I'm doing right now for you. You will correct me if I'm wrong, but I do know that he has a deep passion for surgical and medical education, and so he's joining us here on Health Vibes this morning. Dr. Dangleben, good morning to you.
Good morning to you.
Good morning. Can you hear me?
We,
We're not hearing. Good morning.
Can you hear me?
we just okay. We may have to take a break shortly so that we can
Work on our
work
audio.
on that audio.
Yes.
Stay tuned,
Who
please.
say health cannot have vibes? Well, Jolly's Pharmacy is proving you otherwise. With Health Vibes, every Wednesday morning on Q95 from 10 a.m. to 11:30. Health Vibes, education, information, and a bit of humor, and not forgetting lots of vibes. Hosted by Carlton Langdo with co-hosts Jacinta Fagan Defo and Trudy Kristen. Jolly's Pharmacy is bringing health and vibes together every Wednesday, so be sure to tune in. Health Vibes every Wednesday on Q95 from 10 a.m. to 11:30. Jolly's Pharmacy, leading the way in healthcare.
St. Mary's chips, a chip for every occasion. Let's go where good things happen. Craving a bite of something tasty but healthy? Then it's time to head to Jolly's Pharmacy and pick up some chips from St. Mary's. Cassava, banana, breadfruit, or plantain chips, the choice is all yours. All ingredients are fresh from the farm and it's healthy. There's zero trans fat, no MSG, and it's gluten-free. So when you're making those healthy choices, always choose St. Mary's. St. Mary's, where good things happen. St. Mary's chips, a chip for every occasion, made with love in the Caribbean. Distributed island-wide by Jolly's Pharmacy.
Oh, and if they say convenience could make a big difference, then you can trust me. I know just where you should be. And that is JP Mega. The one-stop shopping, Dominica, nigga. You could be shopping and having fun. With your daughter or with your son. We cater to everyone. What a happy place. Oh, JP Mega. The one-stop shopping, Dominica, nigga. You could be shopping and having fun. With Papa and Mama along. We cater to everyone. What a happy place. Oh, what a happy place. Purchase 6 or more of any item and you automatically qualify for a discount. Check us out at the Mega Store in Funkole, where there's lots of parking on Monday to Friday from 9 a.m. to 7 p.m. On Saturdays from 8 a.m. to 6 p.m. and on Sundays from 10 a.m. to 2 p.m. JP Mega, the best family shopping experience. Who say health cannot have vibes? Well, Jolly's Pharmacy is proving you otherwise. With Health Vibes every Wednesday morning on Q95 from 10 a.m. to 11:30. Health Vibes.
Can you hear me?
Information and a bit of humor, and not forgetting
All right.
lots of vibes. Hosted by Carlton Langdo with co-hosts Jacinta Fagan Defo and Trudy Kristen. Jolly's Pharmacy is bringing health and vibes together every Wednesday, so be sure to tune in. Health Vibes every Wednesday on Q95 from 10 a.m. to 11:30. Jolly's Pharmacy, leading the way in healthcare.
Again, you are on Health Vibes this morning, and we do have a very important discussion, and we will be discussing surgeries, what you need to know, what you may know, what you do not know, and everything that is involved with surgeries. And this morning, as Trudy said, we have a very, very important, prolific surgeon, someone who is Dominican, someone that most of us are extremely proud about, and that is Dr. Dale Dangleben. I was told that he's from the community of Point Michel. Dr. Dangleben, good morning to you, sir.
Good morning. Good morning. Thanks for having me. I'm a trauma medical director at Penn State Holy Spirit. That's the only
Okay.
correction.
All
Yes, I
right.
am proud to be from La Pointe.
Ah. La Pointe, massive.
Yeah, Point Michelle, Point
Yeah.
Michelle.
Yes.
Doctor, you know, we've been on since 2014. We've been doing this health show, and we've never had a surgeon on before. We've never spoken about surgeries in detail. It is one of the medical procedures that is done primarily every day in all parts of the world. It is one that many times people have concerns, they dread, they fear. Some people, it would seem like going under the knife for whatever reason, and some people they dread it. Tell us a little about, maybe in a nutshell, very very short, why you chose surgery and how long you've been in surgery, and just at least an icebreaker.
Yeah, absolutely. Um, well, I've been a surgeon for 23 years now. I've been in the States for 31. Why did I? I always say that surgery chose me. Um,
Mm.
Someone I was dating at the time, I wanted to be a chemical engineer, and I declared my major chemistry. And then I met this young lady whose father was a surgeon. He was from Haiti, and he ran a free clinic in Queens, New York. But he was a trauma surgeon in the Bronx, and it was he, an Indian guy, and an African guy, giving back to the community every Tuesday and every Friday night. And my girlfriend at the time was running the clinic for them. And that's when I first got introduced to medicine and decided to go on to pre-med and change. I kept my major of chemistry, but I changed to pre-med. And like they say, the rest is history. So I credit this person for really directing it. So surgery chose me. And Dr. Guignard, rest his soul, who was a prominent Haitian cardiothoracic surgeon, came to the US and did trauma, and a few other doctors had a significant influence in me going in that direction. And I went into medical school with that in mind. Most people go to medical school and decide, well, I'm going to think of what I want to do. I went to medical school knowing I wanted to become a surgeon.
Wow.
I want to follow up, Dr. Dangleman. I mean, I know a lot of us, maybe, in this generation, my generation, look at Grey's Anatomy and we look at the different surgery specialties that are represented, and the thought process that went into, choosing the particular one. So for you, trauma surgery specifically, why that?
Yeah. Well, when I left med school, I really wanted to be a transplant surgeon.
Okay.
That was because the surgeons that I hung out with during medical school, they were mostly transplant surgeons. I used to go out into the field to harvest the organs with them, on the private planes and all that fancy stuff. But when I went to Lehigh Valley, where I did my residency, they only did kidney transplants, and they did not do the liver transplant and the pancreatic transplant and things like that. And it was one of the biggest trauma programs actually in the country. It was the first trauma program in Pennsylvania, and that's where I trained. So I just fell in love with trauma. And the beauty of being a trauma surgeon, like you said, I'm double boarded. I also I'm critical care. I'm also the director of the ICU, the trauma ICU here, because you get double boarded, and I'm also boarded in surgical critical care. So I can be an ICU doc. I could do general surgery. I did advanced laparoscopic surgery. So that offered me a path into several different things. Wound care, which I know Dominica needs. I've done a few wound care things in Dominica. So it opens the doors to a lot of things. And when these hands can no longer work, I can sit in the ICU and manage critical care patients from a cerebral standpoint.
Mm.
But Doc, you mentioned about having the beauty, of being a trauma surgeon, but to be in that field, you need to think on your feet and remain calm. I mean, that's something that's very, commendable to you. So it meant that when you decided to be a trauma surgeon, that you're able to think quickly. So what allows you to remain calm and think critically in those moments?
I think it comes with time. I can tell you, my first 2 years as a resident, it was pretty. And I had young kids at the time. It's very scary, especially when it's pediatric, especially when it's pediatric patients. Can you deal with that? Can you deal with that? But once you start thinking about it as, you're really there to save a life, I think that put things into perspective. And I think that's what really, by the time I was a third year and fourth year resident, that had already changed in my mind that, you're giving it the best shot to save a life. And I think that's the rewarding aspect, of it. And right now, I started this program here 7 years ago. I was the only trauma surgeon here, starting this program from scratch. And now we have come July, we'll have 8 trauma surgeons. We're doing about 3,400 traumas a year. We just did 48 last weekend. I was on call. That's why I look so tired. But the key is, you're absolutely right. The many people who are new to it will panic, and that's the key. That's the key. I call the trauma surgeon in the trauma bay the team leader, and you have to be in charge and make sure the distractions are not there and stay focused on what's going on. Does this patient need to go to CAT scan? Does this patient need to go to the ICU, or does this patient need to go to the interventional suite or the operating room? So these are the kind of things. So you always need at least 1 or 2 level-headed people in the trauma bay, and I think that's important. But time. But the young folks, when it's the young folks, it's always hard. Whether it's a kid getting shot, whether it's we see the drowning victims, 2-year-old, 3-year-old. These are very hard. We had one incident when dad was backing up his car and the kid did not see his 2-year-old son. These are tough. And we cry sometimes, even if it's inside, but you're there to focus on saving these lives.
Oh, thank you so much.
Thank you. I think all of us are really getting into an insight as to what your job entails. But for us here in Dominica, surgeries are primarily done on Tuesdays and Thursdays at our main hospital. But you do have emergency surgeries happening every day when the need arises. How do someone prepares? Someone has gone to see the doctor. They've gotten a diagnosis, and you're told we have to do surgery. How does someone prepare for surgery from a psychological standpoint and a physiological standpoint?
Yeah, that's important. And before I get into that, all trauma surgeons are general surgeons. So we do elective surgery. So yes, we do have a practice in terms of seeing patients and doing whether it's the gallbladder or the appendix and things like that. I think it starts with your family physician and having a good rapport and a good relationship with your family doc, who usually makes that referral. And usually family physicians refer to surgeons they know that are competent or they've had a relationship with through the years. I think that's important, especially to put the patient at ease. But when you see the patient in the office, I've always been taught to sit down, sit down with the patient, don't stand over them. Even these little things, and having a conversation based on your knowledge of the disease, right? So if it's acute cholecystitis, which is inflammation of the gallbladder, you're going to sit down and explain to them, what is acute cholecystitis? How am I going to approach this? And I think once you have the trust on that level, then you see, I think the patient's getting, more relaxed and more comfortable with you. If you go in there and you bulldoze and you don't take the time, you just say, okay, I'm going to take your gallbladder, I'll put you on for Tuesday, see you then there is, you will see that patient maybe asking for a second or third opinion. So I think the first interaction, I think, is very important. Now, if it's a cancer surgery and you know that preoperatively, that would be best referred to a surgical oncologist. Now, I know maybe Dominica does not have that privilege to have the subspecialist. But that's somebody, if somebody comes to me and said, doc, I have this, colon cancer and I have one lesion on my liver, I'm going to say, you know what, you better serve with a colorectal surgeon or surgical oncologist, and this is why, and send them to that specialist. So I think the conversation, the communication is what's important. And I know we've lost some of that. We've lost that idea of sitting down with the patient, holding their hands, because yes, it is scary. I've been a patient. I've had surgery. So, it's a tough situation. I had hernia surgery, which is not, oncologic surgery, but surgery is surgery, and it's scary going under anesthesia because you don't know how you're going to react. You know what I mean? You don't know if you have a bleeding problem or if you have a clotting problem.
Allergy.
That's going, so you see a lot of these things, and I think sitting with the patient, holding the patient hand, explaining it to them in their terms, not using big terms. For example, I use the word acute cholecystitis. I will use that, but then I will explain to them, what is that? You know what I mean? So I think that's the first thing with general surgery or any surgical procedure. And I think it starts with your family doc that you have a good relationship with. And everyone should have a family doc.
But Doc, I have a question to that rapport building, because with us as pharmacists dispensing medication, many times patients look at the side effects and they may make a decision whether they will take the medication or not based on that. With surgeries, I know that you have the right to disclose the risk factors, associated with surgeries. Do you use your discretion as to what type of risks you disclose to the patients because of their fear of the surgery? How do you?
No. You have to disclose every the consent. Our consent. When I started training, the consent was 1 page. Now the consent is 2.5 pages long, and it really entails it's detailed in terms of what I'm going to do, how I'm going to do it, what are the risks, what are the alternatives to surgery, and things like that. But no, in terms of going through your med list, I think that is so crucial with any procedure. Now, somebody would say, well, this is a minor procedure, right? This is a major procedure. And I tend to explain to patients, what is considered a major procedure. In anybody's mind, any procedure is major, right? But in terms of naming things, heart surgery, joint surgery, these big surgeries tend to be considered major surgeries. And you really have to drill down to the medication list, and not just the medication, the herbs and everything else that this patient is taking that could potentially, cause a problem, during surgery. So as a surgeon, it's important. And inpatient is good because we have a huge pharmacy department in this hospital, and they literally manage everything from the TPN, to all the, reconciling the patient's list with our advanced practitioners. So that's well sorted out. But I think you have to look, in answering your question, you have to look at every medication on that list, because you would be surprised that, oh my goodness, I did not hold that medication, and that's why this patient is oozing more than usual and at risk for further bleeding.
Okay, thank you.
I had Doc, I had some questions about you spoke about the pre-preparation in terms of discussion with the physician. I want to ask a question about, the actual going into the hospital for your surgical procedure, your surgery. I have been, I would say, unfortunate to have had several surgeries in my past, and one memory I have of having a major orthopedic surgery is that I had to be shaved completely before the surgery. I was not aware that was something that had to be done. I remember going in for another procedure, and they said that I was supposed to have removed nail polish. So some of these little things, I'm interested in the why behind them, and what are some other things that maybe people should know when they're going in for surgery? Yes.
Yeah. The shaving part, I think, was very important in terms of, hygiene and post-operative infection and things like that. The nail polish is actually, I think, usually for the pulse ox, documenting and your oxygenation and things like that. It will give you false reading. But again, these are things that can be removed in the pre-op holding area. You know what I mean? So, for example, if you have a thick fake nail and polish over it, and you put that pulse ox, how accurate is it? So I think that's really the scope. The scope of these preventative things is really to, again, address the infection and the potential complications that might happen because of the type of surgeries that you have. You know what I mean? So I think that's why you were told.
I would say the same thing is applicable, because many times patients are told prior to surgery, but 12 midnight, you cannot have anything to drink, anything to eat. That is one of the common things that we see. You may have to get blood donors as well, depending on the type of surgery that is going to be done. And sometimes people want to cheat. They might see their loved one, especially children, crying, I'm hungry, I'm thirsty. And you as a parent, you may want to give that patient that water or juice or food item to consume. What is the relation with these, when these disclaimers and guidelines are highlighted? Patients should have absolutely no food, and even sometimes after the surgery is done, maybe for an entire day, you still cannot consume any food or any liquids.
Right, and that goes right along with anesthesia. I can tell you, I had a patient scheduled for hernia, and then he came in, and the nurse came and said to me, "Yeah, he stopped off at McDonald's. Yep, case is canceled." That happens, but you're absolutely right. It put you at risk during intubation for aspiration, right? Now, there's been several lawsuits, in that regards. Patient aspirated, developed pneumonia or acute pneumonitis, and ends up, dying from these things. So again, to reduce the incidence, this intraoperative or postoperative incidents, you have to have these rules. Although based on the type of medications that you're taking, you can say, hey, the morning off, you can have your beta blocker with a sip of water. It's very specific, not a large glass of juice, just a sip of water. Or it can be done under supervision in the holding area. But anesthesia is the stickler for this. You will not proceed with the case if you've eaten after midnight. And I think it has to do with having food in your stomach, and upon induction, intubating, vomitus comes all the way up into your passive vocal cords, into your lungs. That's a disaster waiting to happen. So again, all these things, there's a reason for that. You know what I mean? The post-op part, I think, is really you coming out of anesthesia. Everybody comes out of anesthesia differently, and I think that has to do with the threshold in terms of the type of medications that you've taken in the past. Some people are medication naive, and some people you give them 25 of fentanyl and they're out. Some people, we had a young man this past weekend. We were up to 250 of fentanyl, and he was wide awake looking at us. And we added Diprovan, and he was still up. We had to go up to 75. So everyone's a little different. So when you wake up, you want to make sure that you have all your faculties. You've seen the YouTube videos of people coming out from anesthesia in the car driving home, speaking things that you don't know what they're talking about. People are still confused. So there is risk with that post anesthesia. You want to make sure that's out of your system. Usually if you stay inpatient, right, we do a post-operative check on these patients, right? We go through all the systems and make sure that they're okay. And then we say, okay, we'll start with clear liquids, and then, or sips of Clairs and things like that, and then go from there. So that is why we do that. Somebody might just wake up and be fine, and, GCS of 15, and okay, no risk. You say, okay, let's give them some food and give them some crackers and a cup of juice and send them home. So I think, again, a lot of this has to do with, medical legal issues and liabilities.
But doctor, let me ask you though, Let us play devil's advocate. And I know you live in a modern industrialized country where you would have seen that. A patient comes in with a gunshot or a stab wound. That patient is a drug addict. They may have
Mhm.
taken cocaine or crack or something, and you have to do surgery on them, which is a drug. In any case, the crack, the cocaine.
Mhm.
Do you
Mhm.
flush them? How do you know? Because we get it into medications and surgeries and some of the complications that could arise. So let's say this patient is a drug addict and consumed or may have taken, one of these drugs prior to the injury. Do you flush them? What happens then?
No, and that's very, very common, by the way. We see a lot of,
Mm,
it seems, a lot of the trauma patients come in, on something.
Mhm.
We do a talks. We do a talks right there.
mm.
Everyone gets the ETOH and alcohol level, and we do send off the talks, but you don't. That does not inhibit us from moving forward with what needs to be done. You just have to be
Okay.
cognizant that this patient has an upper or this patient has a downer, and anesthesia will pay attention to that if we're going to the operating room, right? So somebody's on cocaine, the hyper, the belligerent, we immediately going to intubate them in the trauma bay, put them out because they're harm to themselves, they're harm to the team. We put them out, they're tachycardic. Again, anesthesia is aware of that, and we're going to pay attention to that in the operating room. So no, there is really nothing unless this patient's overdosed on Tylenol or something like this, and we want to give some charcoal and and acetylcysteine and things like that, or Narcan. We do give Narcan, for the reversal of the opiates. Other than that, no, we really just move forward with the trauma situation that needs addressing. We don't sit and wait to address these specific things.
Okay. Doctor, I wanted to talk a little about blood clots because that's a major complication that people experience. You would have heard, I know of cases where, the surgery was successful, the person awoke, they may have done their first walk, a second walk, and then subsequently they end up having a blood clot and dying. Blood thinners are often given um, after surgery. There are sometimes varicose stockings. Those are recommended too. But how common is this, and what can we do? What can the patient know in terms of protecting themselves? In terms of, is the blood clot issue for all surgeries, complications to all surgeries? And what are people supposed to know and should do
Yeah.
about protecting themselves?
Yeah, I think everyone is at risk because and folks have to realize that the insult actually happens because of your immobility during surgery, right? So remember, folks, when you're on a plane and you're sitting in the same position for 5 hours, you get that clot. It's the same situation. So I think it's important. It's important to know that going into surgery, that puts you at risk for clots to begin with. And yes, we do put the SCDs, which is a sequential compression device, on both legs. But there's a subset of patients. You have to look at every patient, right? There's patients that's on Coumadin. There's a patients that's on Eliquis and Xarelto and all these other new medication. You're holding it, and there's a reason why they're on that. It could have been a previous DVT and PE. What is the timing of starting these things? All these things are important. But getting back to what we're saying, you also have to decide what is the risk. So patients with cancer, for example, have a higher risk of DVT. So if you're having an
Mm,
oncologic procedure, whether it's a uterine cancer or an ovarian cancer, you just by having cancer, you already at a higher risk than the normal person undergoing anesthesia for having DVTs and having this clot. So all these things you need to know. Orthopedic surgery puts you at higher risk, right? So you're going to be less mobile because of it's a long bone injury, it's a pelvic injury, and things like that. So I think it's extremely important to know the category of patient that you're dealing with and knowing how long that you're gonna, keep these patients on something to thin the blood, knowing that there's a risk of bleeding because you just had surgery. Now, orthopedic surgery, if you had hip surgery or knee surgery, nowadays days up here, they're extending your post-operative aspirin. They're using that a lot now, right off the bat, to keep you on the aspirin for maybe a good 2 to 3 weeks until you're mobile enough. In trauma, we use a lot of what's called Lovenox, which is enoxaparin, right, which is a low molecular with heparin, right? And again, if this patient has major surgery and is risk for bleeding, we got to hold that. But there's another subset that I want to talk about. There is patient that has underlying genetic conditions that they're not aware of. And these are the patients that usually get up post-op day one and just drop dead. Factor V Leiden and Factor V Leiden and all these other genetic dispositions puts you at risk for getting clots, right? We had a 48-year-old, she fell down 12 steps. She was intoxicated, she broke her leg. She went to surgery and never woke up. She had a massive PE within 5 hours of being here, and then we found out she had Factor V Leiden. So these are the kind of things. If you have a family history of patients, clotting and in the legs and PEs, you might want to get checked that you don't have one of these genetic conditions that predispose you, because it's important to know that going into any surgery. Because if your surgery is going to be longer than 2 hours and you're on that table under anesthesia, immobile, you're at higher risk of developing a clot post-op that's going to eventually, go to your lungs. And so again, it's everyone's at risk. Answering your question, everyone's at risk from a surgery standpoint. But in terms of your VTE score, it goes up based on what your issue is. Cancer, higher. Broken hip, broken pelvis, higher. So there's a scoring system called the VTE score, the venothromboembolism score, that you could calculate as a physician based on what the patient has. That gives you a sort of a risk stratification of that patient.
Would you say that, one second, would you say that obesity could also be a risk factor with blood clot and surgery?
100% on that VTE score. Yes. Obesity is one of the major factors. Not only that, one of the things that we see with morbid obesity, in terms of the bariatric surgery, the weight loss surgery, a lot of heavy people, the mega obese, the BMI is greater than 50, just by laying on the table for 3-4 hours, they can develop rhabdomyolysis, muscle breakdown that affects your kidneys. It's been documented. So morbid obesity affects everything. It affects you on the breathing machine with a tube, right? Down. That is going to affect your kidneys, right? It's going to affect your kidneys, especially the rhabdo, but just overall being unhealthy and putting you at risk for clot is a big thing with morbid obesity. So yes, I think that has to be outlined and said many, many times. If you're morbidly obese and you're going through surgery, you have a higher VTE score and you have a higher risk of clotting and pulmonary embolism down the line.
Doctor, I wanted to follow up on something you mentioned, people having predisposing factors, maybe like a genetic condition predisposing them to clotting, or maybe people having other medical conditions that put them at higher risk for certain negative reactions, even allergic reactions. And people coming in or not coming in, but people being brought in after an accident or something like that. How... without the method of medical alerts, which in Dominica we don't have, how is the operating team, the physicians, what can be done to prepare for, or what can the patient possibly do? And I really want to talk in our context locally to ensure that you have an emergency. The people who are going to work on you know of your pre-existing conditions.
Yeah. putting it into Dominica concept is difficult. And I'm gonna shift a little here. In 2019, we did a wound clinic. Dr. Jolly was there with us in Point Michel. People were bringing the notebooks with all their medical records and asking me to read it for them. And I can tell you, one of the things I was appalled at is I could not read what was written by that physician. And this is 2019. I couldn't read it, much as the patient. So I think documentation is an important thing. Having a medical record database is important. I did send a couple of laptops. I'm not going to get too deep into that to start a medical database for Point Michel, at least, because when we came down after Maria, patients were saying, well, I'm on this little pill. They did not know what pill they had, and their books went with Maria. Their books went with Maria.
Yes.
So I think that's a huge issue in Dominica. And I am more than willing to, we have the means to build these medical records and this database, because it's in the cloud. If it's in the cloud, any pharmacist, any hospital, any medical care can access it when that patient shows up. We have Epic, we have Cerner up there. So when that patient is coming, even if they don't know, then you have the record and you can know. And not just the family physician. The patient comes to the ER, they can access it. The patient comes to the ICU, we can access it, right? So I think that's where we need to go. These notebooks have to be gone. It's 2023. We need a better system of educating patients, one, on what is wrong with you. Because I could tell you, we saw quite a few patients that day there in Point Michel, not just from Point Michel, they came all the way from Petit Soufrière, wherever, to get their wounds checked. But folks did not know what they were on, and the writing. We need to move away from writing. This is coming from a physician. I spent my first 10 years, scribbling, and we have to move away from that. One, so documentation, right, and education, I think, is important. So the patient, many of these patients, let's be honest, some of them are illiterate. And even if you ask them, they will not be. The only thing they can tell you is some descriptive thing. Well, this is a blue pill. This is a blue pill. This is a wrong pill. We need to do better for the patients in that regard. So if we could create a system, which is one of the things that I hope for Dominic, I presented that in 2014 and 2015. Then they come to the pharmacist. The pharmacist has access to the cloud. They go to the hospital. The casualty has access to that cloud. And there's ways of doing it. So in terms of, I don't know if I'm answering your question, but I think that is the thing in terms of patient knowing what's wrong with them. And if it's one problem that patient has, you sort of repeat it several times into their head, and you tell the family, you tell the younger members of the family, it's not just a blue pill. It's hydrochlorothiazide. It's this, it's that, and this is what it does. It's a water pill. And then you have that kind of conversation. And I think it's important, and you don't need a physician to necessarily drive that. It could be a pharmacist, it could be a nurse practitioner, it could be a physician assistant who's responsible for these things. But education.
Because I'm really feeding on what Trudy said, because what we've seen here is an accident occurs or happens, the ambulance comes, the firemen come, they put you on a stretcher, and that's about it. And then they drive us fast to the nearby health center or hospital, and the doctor there, I don't know if there's any communique as to, okay, we're coming in with XYZ, blood pressure is whatever, XYZ, and so people are scrambling because they're not prepared. And how can we get our system on that level? Well, I suspect that's going to be a bit value laden to answer, because it's something that
I have been there.
It's serious.
You know, I have tried to address these things. I met with the fire department. Matt took me there in 2014 or 2015, and I met with them, and I told them how I could help. I also gave the hospital 52 protocols, guidelines, which was never utilized. But you're right. The command is central command is very important, right? You could rush out to the field and grab a stab victim, and rush them to the casualty, and there's no one there to receive the patient, right? Even if it's 5 minutes. So what we have here, we have the trauma alert system, we have a tiered system, right? So we have a level 1, level 2, and then we have the trauma consult. A level 1 is anyone with, you know, hypotension, gunshot to the chest, gunshot, you know, there's specific criteria for that. So when you get level 1, everyone has to be in the bay. Anesthesia is there, the operating room staff is there, everyone is there, and we're ready to go, right? So if you're going to set up a system, it has to be set up in such a way that the information that you get, you act upon, right? So, and I see that repeatedly, that information is documented and not addressed and acted upon. So I think putting a system in Dominica is relatively easy to do, because Dominica is not that big in terms of size and population to implement such an issue. And I've always said this many times on Q95, you know, with trauma, time is life, you know, or death, right? And when you get to the hospital, there has to be protocols, X, Y, and Z, that's going to have to be done, right? And you have to always have operating room availability. So not, you know, I don't want to compare this hospital to Dominica, but we can run 2 rooms at night, no matter what, right? There's about 20 rooms running during the day, but we could run 2 rooms, and then there's a backup. There's an anesthesia and an OR backup team to come in just in case we have a mass casualty, right? So you could use these models, and all the protocols in this hospital I wrote, and I'm willing to share these things to make things better for Dominica, because I have always said some people are dying and we can do better. Some people say, well, it's your time. We come from a very religious culture. When it's your time, it's your time. But I've always said there is something called a preventable death. Right? If somebody, what if somebody takes a medication that is prescribed by one of you guys and has a reaction, and it's an airway issue? You know, we have that. We have a non-trauma airway emergency protocol in this hospital, right? Just in case this patient is intubation, tracheostomy, or cricothyrotomy, all these things are in place. So I think as a country, we can do better, you know, for our people.
Okay. Let's see if we can give the numbers. There's some people that may want to ask you some questions. The numbers are 449-3095, 449-3096, 449-3097, 616-4257. And of course, you're always welcome to call from overseas. And that number is 305-432-9624. So Dr. Dangoben can answer some of the questions that you may have. You may have had a surgery and you may have had an experience, or something may have happened, or there is a question. You might be pending surgery and you may want to ask him as the expert questions that you may have concerns about. Feel free to do so whilst he's on the show. There was a question I wanted to ask you though. Yes. So prior to surgery, is it protocol that, okay, we have a caller. Let me take this caller and then afterwards we'll ask. Thank you, caller. Thanks for asking.
Hello, good morning.
Good morning.
Good morning to you, sir.
You hear me clearly?
Yes, I am.
Okay, I'm calling from Asia, and I'm a Dominican. I'm listening very carefully. And Dr. Will, I'm proud of you, and I'm very impressed. I've been listening to you for a long time. 2 questions I have for you, Dr. David. The one is in detail. The first one is, what's the difference between a surgeon, trauma doctor like you, I don't want to say the ordinary doctor, but those who we go and see on a daily basis, who are in the hospital. And is it possible, or is it needed, or would you recommend that in every hospital, a major hospital in Dominica, or at least the central hospital, there should be a trauma doctor? For one reason, I have seen this happen over and over. People fell, damaged, and as a result of the fall, they die because maybe some doctor do not know what to do because that's not easy as a trauma doctor. I just want to know, is it important to have a trauma doctor by a major hospital?
Thank you, caller. Thanks for your question.
Yeah, well, that's impossible. Dominica doesn't have one trauma doctor. So Dominica does not have one trauma doctor. So in terms of your answer, that's not going to be possible to have one in every you know, you need one or two in the main hospital. Even up here, not every hospital is a trauma center, right? You have to go through accreditation every 3 years to maintain your trauma accreditation. So not every hospital is a trauma. So in terms of getting a patient to a level 1 or level 2, that's a different discussion. Now, what makes us different? And I always get not upset, but I like to clarify that I am not an ER doc. No disrespect to ER docs. An ER doc takes 3 years of training. I did 6. Okay, that's the huge difference between being a trauma surgeon and an ER doc, because I think a lot of folks tend to misunderstand. An ER doc cannot take you to the operating room and operate on you. Trauma surgeons can. So that's one of the clarification. But you need to train the surgeons that's on island to be trauma docs and how to address certain situation. You know, when to recognize that this patient has an internal bleed that needs to be taken to the operating room and opened up and packed, or remove the spleen or pack the liver and things like that. That's what needs to be done. But absolutely not to your answer to your question about every, you need every village clinic to be open, and that's not the case, and staffed, but not with trauma. You need to figure out a way to get the patient to a central location where you can operate.
Go ahead,
Dr. Dangleband. I had a question as it relates to incidences of trauma and the need for diagnostic tests prior to treating the patient. Of course, we know, we have limitations as it relates to certain, diagnostic procedures that we may need. I wanted to know what is really necessary in your line of work. Are we talking X-ray capacity, MRI? What is really necessary to make quick decisions for a patient that may come in, an accident or burn victim, whatever it is? What should we prioritize in terms of diagnostic capability at our hospital?
So again, we have 2 ultrasounds in the trauma bay. That's the key. So if you're going to need things, it's going to be an X-ray machine and an ultrasound machine. Okay? And the reason why I say that is, if a patient is unstable, meaning that the pressure is low, the pressure is below 100, the patient is tachycardic, the patient is out of it, you've intubated the patient, right? You take the ultrasound probe, you put it on the belly. If there's fluid in there, you go straight to the operating room. You're not doing MRI. As a matter of fact, it would be gross malpractice if I now take that patient with fluid in their belly who's now unstable and take them to CAT scan. That's a no-no. You go straight to the operating room. That's called a positive FAST, the focal abdominal sonography of trauma. That's a big thing. You look at all 4 quadrants and the heart, right? It can also now show you, the ultrasound can now show you whether or not you have a collapsed lung. So you really don't even need the X-ray for that now. But it's important. You go to most trauma centers in the United States, we instant X-ray in the trauma bay. So you shoot it, and it's right on the screen, right there, digital, right? You don't, again, it does not need to have that, but you need to have, even if it's an old school X-ray, I can give it maybe within 4 to 5 minutes, that you could put it up and say, hey, this is what's going on. This patient has free air in the abdomen. This patient has a tension pneumothorax. We need to move, right? These I think is important. A CAT scanner. The third thing is a CAT scanner, especially for the head injury. Right? You want to move quick, and I think a lot of folks in Dominica, I think it's because of lack of diagnostic head injuries that folks are dying when they hit that, especially if you're drunk. Did I answer the question?
I think you did.
Yes.
We seem to be having we were having some difficulties hearing you clearly. I think it may be something to do with the internet. We're not too sure. What we're going to do, we're going to take a short break, and then we will try to see if we can get it rectified so we can hear you much clearer than just a while ago.
Oh, and if they say convenience could make a big difference, then you can trust me. I know just where you should be. And that is JP Mega. The one-stop shopping Dominica, nigga. You could be shopping and having fun. With your daughter or with your son. They cater to everyone. What a happy place. Oh, JP Mega. The one-stop shopping Dominica, nigga. You could be shopping and having fun. With Papa and Mama and love. They cater to everyone. What a happy place. Oh, what a happy place. Purchase 6 or more of any item and you automatically qualify for a discount. Check us out at the Mega Store in Funkole, where there's lots of parking on Monday to Friday from 9 a.m. to 7 p.m. On Saturdays from 8 a.m. to 6 p.m. and on Sundays from 10 a.m. to 2 p.m. JP Mega, the best family shopping experience. Who say health cannot have vibes? Well, Jolly's Pharmacy is proving you otherwise. With Health Vibes, every Wednesday morning on Q95 from 10 a.m. to 11:30. Health Vibes, education, information, and a bit of humor. And not forgetting lots of vibes. Hosted by Carlton Lango with co-hosts Jacinta Fagan Defo and Trudy Kristen. Jolly's Pharmacy is bringing health and vibes together every Wednesday, so be sure to tune in. Health Vibes every Wednesday on Q95 from 10 a.m. to 11:30. Jolly's Pharmacy, leading the way in healthcare. Oh, and if they say convenience could make a big difference, then you can trust me. I know just where you should be. And that is JP Mega. The one-stop shopping Dominica, nigga. You could be shopping and having fun. With your daughter or with your son. They cater to everyone. What a happy place. Oh, JP Mega. The one-stop shopping Dominica, nigga. You could be shopping and having fun. With Papa and Mama and love. They cater to everyone. What a happy place. Oh, what a happy place. Purchase 6 or more of any item and you automatically qualify for a discount. Check us out at the Mega Store in Funkole, where there's lots of parking on Monday to Friday from 9 a.m. to 7 p.m. From 8 a.m. to 6 p.m. and on Sundays from 10 a.m. to 2 p.m. JP Mega, the best family shopping experience.
So we're back with Dr. Dale Dangoban, trauma surgeon, and we're so happy to have him on this morning. You know, he's a very busy person, and he really took the time to share with us and his knowledge on trauma, his knowledge on surgeries. I think one of you had a question. Doctor, are you hearing us now?
Yeah, can you hear me?
Yes, we are. We are.
I'm using I was using my iPad before that, so I don't know what.
Okay.
Yeah, I don't know if our listeners heard everything, but in the last response, I think Dr. Dangoban, if we just have to recap, you mentioned of necessity ultrasound, X-ray, and
CAT scan?
What was the third thing? That's where I think we
Ultrasound can look at the abdomen and the heart and the lungs now for you to make a quick decision. X-ray, obviously, in the abdomen really doesn't show much, but if you have free air or air leaking from the gut, you'll see it under the diaphragm. You could act on that immediately, go to the operating room, or it could show you whether or not you have a hemothorax or pneumothorax, which is collapsed lung. A CAT scan is important, I think, for head injuries. And I was saying that I think a lot of Dominicans, fall, hit the head, have a subdural or epidural type of injury, and which requires, prompt, action. And I think, they're not getting the CAT scan, I think, affects that tremendously in terms of rushing to the operating room to decompress the brain. So I know I donated some drills in 2013 through Matt Peltier. But when I came down to give the lecture in 2015, they were no longer available. So I don't even know if there's drills for the brain in Dominica to at least even do burr holes, which is literally just taking a drill and drilling a hole and let the blood, right? They used to do that in Egypt 5,000 years ago. So anyway, I'll leave that there.
Okay, so Doc, I have a question. So sometimes there is a specific purpose for surgery. But when you actually open up the patient, whether it's abdomen area or the brain, you encounter something that you didn't see on a scan. What determines what decision you make at that point? And I know sometimes if it would affect another organ or it may affect your mobility in some way or any other area, is it that you close up the person and speak with a relative, next of kin? What drives that decision?
I can tell you a lot of times, for example, you go in and do a colon resection, it turns out to be cancer. There's what's called carcinomatosis, which is a little stud in the abdomen itself that you really couldn't appreciate on CAT scan, or there's a nodule in the liver, which is where the colon cancer tends to first spread to. I think it's important to capture some of that in your consent preoperatively. If we find this, then we're going to do this, possible that, right? So you don't have to close that patient and come back out. If this patient has carcinomatosis, which is cancer all studding the entire abdomen, you're done. You're going to close. If this patient has a bowel obstruction, you might just bring out a colostomy as a palliative procedure and talk to the family. You're not going back. Okay. And I've been there. We've all been there in situations like this. But I think if you're taking the gallbladder out, and I'm going to say this very carefully because I know there was a case in Dominica. If you're taking the gallbladder out and you see a lesion on the liver, you take the gallbladder, especially if it's close to the gallbladder, because gallbladder cancer extends into the liver, right? So you could take that out and take a little bit of the liver and send it to pathology for, So there's several ways of dealing with situations like this. And preoperative staging, I'm talking about the US, is so good these days, right? If you have somebody with a lung nodule, right, you're going to put them through a whole array of preoperative studies, including PET scans, right? Where else is this thing lighting up? Which nodes are involved? Is this a stage 3? Is this a stage 4? Is this a stage 5? Right? Stage 4, 5, you might not operate and try to do some palliative, things like that. So I think it's important that we move the medicine forward to that point where we can get things that can help us. So the question that you ask can be reduced. So I don't have to always, run out and talk to the family. That's another thing. You can keep the patient open for a very short time, and I'll tell you guys a quick story. There was a young man, he was 42 years old. He was out in Colorado skiing, and he developed some right lower quadrant pain, and he went to a little hospital there, and they told him he was fine. He was seeing me 6 months later. He had a cancer of his appendix that spread in his entire, but he presented to me because he was jogging. He says every time he jogs, he hears this squishing sound in his testicles. So if you have a hernia, your testicles and your scrotum is really connected back into your peritoneum, right? He had cancer that spread from his appendix all the way there, and that's what he was there. I put the laparoscope in, and it was everywhere. I have one of my poems is about that because it was very sad. I sent him to New York, and within a year and a half, this young man was dead. But that's the whole point. Sometimes you do go in and you can do nothing. The key is to be vigilant enough way in advance, so we don't get to that point. And
Doc, I suspect we have a few calls. There is someone who wants to ask you a question. Let's take it.
Sure.
Good morning to you.
Hey, Carlton, blessings to you, truly blessings to you.
Good morning to you. Good morning.
Dr. Bill, blessings to you, and thanks for service to country and humanity. Your efforts we all recognize it, and we know what you're up against in this blessed land. But my brethren, all I can ask you to do, please do not give up on us. I understand our predicament, and thanks again. Thank you for all what you have tried and is still trying. God and is doing. God blessings, and I am there learning. So thanks again. Blessings.
Thank you, blessings. Yeah, man. Enough respect. Enough respects and blessings to you too.
Good morning. Good morning to you, caller. Thanks for calling.
Yes, good morning. A very educational program.
Thank you so much.
Morning to all your guests,
Thank you.
including I'm Dr. Dangleben. Dr. Dangleben was just saying something there, and I was trying to call earlier on to ask that question. Sometimes the doctors know that the patient is going to die, and they still operate on the person. You know why? We had a case once at work. The lady was sick with cancer, and they operated on the lady. And all the lady intestine, everything was, it was just in a mess. And a few days after the lady died. So they should know, when a person comes to them, if the person is going to die, or if the person is not going to die, or, or something like that. Because, when the people come to the rehab, it is so painful for them and the workers, to see these people in that condition. So my question, if you know a person is sick, especially with cancer, and then you do all your different tests, and you know that person is going to die, why you open that person? Why did you operate on that person? That's my question.
Thank you, caller. Good question.
Yeah, no, it's a good question, but it's a tricky one. Sometimes you have to operate, especially when it comes to the intestine, because you want to it's a horrible way to die from a bowel obstruction. Sometimes you just want to go in and relieve the bowel with a bag, because this patient might have 2-3 months, and if you keep them obstructed, that's very, very painful. But if the cancer does not always mean death, right? Because we would not be here having this discussion. So we cannot just say carte blanche, well, you have cancer, you're dead. That's not true, because there are survivors. And that's why I think the TNM system, the tumor, the node, and the metastasis system, which governs the staging of cancer, is very important. So, in Dominica, we need to have discussions. We need to have what we call it up here. We call it tumor board. We call it tumor board, where the radiologist, the pharmacist, the surgeon, everybody comes and have it. We present the case and we say, hey, what is the best way forward? But staging is important. So I cannot say, well, the patient has cancer, just write that patient off, or we operated. Sometimes you go in and you find things that you did not expect, like based on that question that you asked. And I think it's important sometimes to do some palliative surgery, to give your loved one that level of comfort for the next 2-3 months. And I think sometimes, putting a tube in, putting a drain in is important. And it helps a lot, refocus, even if they're going to go off to a hospice.
Doctor, I know we're running out of time, but I want to ask you a question. Dominica, we like our bush, we like our herbs, we like our, whether it's in tea, whether it's in capsules, whether it's in potions, whatever it is, we like that. And oftentimes patients hide, or they lie, or they don't tell the doctor. The doctor says, are you taking anything? No, I'm not taking no medicine. But they're drinking all different types of bush. And then these are the same people that is due for surgery. How important it is to be honest with your surgeon and let them know, particularly herbal medicines, whether it's in a raw form, whether you buy it from the pharmacy or by the roadside?
Very, very, very important question, and I'm happy you mentioned that, because I think that's a huge issue to discuss. The same way you're going to talk about, aspirin or ibuprofen, you should always talk about the herbs that you're taking, because I think that's a misconception that we have, because a lot of herbs, you got to stop it 7 to 14 days before surgeries. The ginkgo, the ginger, all of these medications, garlic, there's a reason why we take them, whether it's for blood sugar, whether it's for blood pressure, right? So some of these medications is a no-no. Echinacea is one, ephedra is another one. These medications, you need to tell your doctor that I am taking these, and they will say, stop it, just as I would tell you, just hold your aspirin, hold off on that. Because most of these medications, these herbs, you know what they do? They thin your blood, including turmeric. And I'm a big proponent. I'm a big proponent of all of these herbs, because I take my turmeric, I take my moringa, right? But you have to understand that it's like a medicine, even if it's not FDA approved and all that stuff. You got to tell your doctor, hey, I'm taking these things, and you need to stop them. The doctor needs to tell you, hey, stop this. Because then you're going to bleed and you're going to say, the doctor messed up, but it was you taking too much turmeric.
And that's a good point, because it's something that many times people hide. They don't. To them, it's my little potion that I'm taking behind closed doors. Doctor doesn't have to panic about that sound. You don't need to know that. I will tell you, let's talk about what you give me, and I will take whatever I want. So I'm glad that you've raised that and you've explained the rationale why, these, whether it's synthetic or herbal, why many times they have to be suspended up to 2 weeks prior to the surgery.
No, I see we have a call coming in.
Good morning to you, caller. Thanks for calling.
Good morning. Good program.
Thank you so much.
Now, sometimes when you go on surgery, sometimes you're not sure of living in it, because when they do an injection, they send you to sleep. It doesn't really sometimes you do the operation and then you wake up, you don't wake up. So sometimes you can't blame the doctor for that. Sometimes it's in a fright when they go and take the surgery and all of that. With reference to the bush herbal medicine, it's a complete different thing towards the pharmaceutical herb. I mean, tablets and what have you, medication. So you have to be careful on the quantity, what quantity you take in terms of the herbal medicine, because there's two different stuff you're dealing with there. You have to be careful, the measurements and what have you. Only that.
Thank you. Yeah. Let's take this other caller one time. Good morning to you, caller. Thank you for calling.
Hello, good morning, gentlemen and ladies.
Good morning. Good morning.
Good morning, Dr. Dangerben. Dr. Dangerben, I have never met you before, but I admire you as a true Dominican, a loving Dominican, a patriotic Dominican. And thank you for service. I appreciate it very much of you and your voice and the concern that you share with all of us, all Dominicans at home and abroad. It's a very interesting program, and I must congratulate Q95 for educating the people of Dominica. I was in Dominica recently, and I asked myself, are Dominicans ignorant, or they selfish, or they've just given up? Because you hear most of them say they don't listen to Q95. Oh, I don't listen to that, But where else can you get the education, politically, financially, medically, and all kind of alley that you're looking for? Only on Q95. And I must congratulate you. I know that I am not hearing any commercial, so I suspect that this is a commercial-free program. And it's very good. It's very good of you that you are educating the people of Dominica at home and abroad on this sort of information. Last week you had a wonderful program. I tried calling to congratulate you.
Thank you.
And it's a pleasure. It's a pleasure hearing you and giving it to us for free. I know you have to pay the radio station, but who is paying you back? And you are doing it for love of your country and educating your people. I must ask the bus drivers who only play this boom, 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 boom on their buses. This is the time to listen to Q95 to educate their riders. You know, most of them don't listen to important programs.
Thank
They're
you.
already naive. They're already ignorant. They're already selfish. They already may have given up already.
Thank you,
They
caller.
have to listen to this. They have to listen to this kind of program
Thank
to
you.
learn and to teach.
Thank you,
So I
caller.
appreciate it. And I hope it will continue.
Thank you.
And thank you very much.
Thank you so
very
much.
Doctor,
Thank you.
for
Thank you
your
so
service.
much. Thank you.
You're
Let's
welcome.
listen to the caller, doctor, before you give your last remarks. Good morning to you, caller. Thanks for calling.
Good morning, Carlton, and your colleagues.
Yes, good morning to you.
Good
ma'am.
morning, Dr. Dangaben. This
Good
is
morning.
Lucille. I do not know you, but I cannot let you go without thanking you for educating your people in Dominica. We are grateful for that. We know you longing to come back to your country, but God is love. Where there is a will, there is a way. Thank you. God bless you.
Thank you. Thank you
You're
so
welcome.
much.
You're welcome. Thank you.
Doctor, you would have heard it, some of the comments that were made. We have to wrap up. I'm going to give you that opportunity to answer some of them and to maybe give some last remarks.
Yeah, you know, I'm thankful that you reached out to me and for this opportunity, because again, you know, education is in my blood. I taught at the academy at a very young age, when I think I was maybe just about to turn 18, you know, and I still continue to educate, and I write textbooks and things like that. But I think one of the passions that I have is to educate our people. We've had several functions in Dominica, and hopefully one day, it's been 3 years since I came back, and there's a reason that I'm staying away. But you know, maybe when I come back, we can do something together.
Definitely.
in terms of education. But there's a lot of things that we need to do to lift our people up. And the basic thing, I think, you know, when they say your health is your wealth, I think that is so important. And I think we've taken that for granted. You know, I lost my young brother last year. You know, we have to be very, very careful with diseases, with what's going on around us, the morbid obesity, the diabetes, the high blood pressure. You know, I am working on a couple platforms and things like that, but I think it's up to every single one of us, especially, you know, what you guys are doing. We got to give you guys kudos on that. But again, I'm really thankful for that. The folks that called in and said the same thing, I want to just say to them, thank you. But you're right. I agree with Blessings. You know, every other week I give up on Dominica, but I keep coming back because of, obviously, you know, my parents are long gone, but this is where I'm from, La Puente. And I think together, if we keep this education going, you know, even like we say in trauma, even if it's one life you save, it's important.
True.
So kudos to you guys for what you do. Continue to do it. You know, the young Jolly that was on here yesterday, I taught him in third form. You know, it's good to see folks that you taught, you know, becoming things. And I think that's what's important. It's not just the education part of it, but the health part of it. And I want to live with that. I don't want to talk more on any of the other things. Dominica is blessed in so many regards. We just cannot afford to lose that aspect of things. And God bless people like you guys.
Thank you so
Thank
much,
you.
Doctor. It was a pleasure having you on. I do hope I will get to meet you at some point when you do visit us at Jolly's Pharmacy. I'm sure I will be able to utilize your expertise at some forum, because we always up to something. And you know, feeling your energy and your passion, I am certain you will definitely collaborate and do something with us.
Yes.
Thank you so
I
much.
look forward to that too. And Dr. Dangleben, I mean, we look forward to visiting you as well. We look forward to that. As I said at the start of the show, I look forward to coming to the art gallery.
Right behind me. I have art all over my office, yes, but my gallery is in Harrisburg, Pennsylvania. Yes.
Nice. Thank you.
All right. So thanks
Thank you,
again,
guys.
Doctor, and do have a good day. Continue being blessed.
All
Thank
right.
you
Stay
again.
blessed, guys.
Take
All
care.
right. So again, here you had it. We had Dr. Dale Dangleben, consultant surgeon, trauma surgeon, and he, you know, has done so much in his field of expertise. So we are out of time. Let us thank QFM for giving us the extra 10 minutes. From all of us here at the studios of QFM, as always, Your health is indeed your greatest resource. Preserve it. Go out and do something good today. Have a good day. Bye-bye.
Bye-bye.
Easy Rock 95.1. More rock, less talk while you work. The latest soft rock. Hit